All right, so talking about movement of the QRS axis to the right or left. So when we're looking at this plane, we have everything that we move is in a three-dimensional space. In this case, we're looking at the heart in two-dimensional space. So you have your AVF, that is your Y axis, goes up and down, and then you have your X axis on the horizontal plane. Lead 1 is going to be our horizontal plane, and then up and down is going to be our Y-axis, AVF lead. I'm sure cardiologists probably have a third dimension that they look at the heart on a Z-axis, but that is way too complicated for what we are doing behind the dumpster at 7-Eleven. So with that being said, whenever we're looking at axis deviation, the whole purpose is to provide important clues about whether the heart has certain electrical activity, but not for any particular diagnosis, but it's one more clue. So the fastest method to determine the QRS axis involves using QRS complexes in leads 1 and AVF in order to create a simple quadrant system. So just like we know with leads, whenever electricity runs to it, if the isoelectric line, it's going to go up on the QRS. And it goes down whenever the electricity is going away from the lead. So with that being said, I'm going to try, I messed this up on the first video. So we need to look at leads 1 is going to be our right hand. And we're going to do this from the perspective of staring at the, if we're looking at the heart from the anatomical view is how this is going to go. So lead 1 is our right hand, and thumbs up means QRS is going up. So again, pretend like we're driving a steering wheel, and our left hand is going to be our AVF. So if that's positive, then we're both going good thumbs up, normal. Electricity is going to the normal direction, good, normal, both thumbs up. Okay, so lead 1, right hand. Now if we have a positive QRS in lead 1, thumbs up, and a negative lead in AVF, negative means down. AVF is our left hand. This is no longer both thumbs up. So it's like this, we're staring at this. Now pretend that we are moving the direction of our thumbs, like we're turning the wheel. So if we go this way, then electricity is steering from normal. We're steering normal to left, right? Just like that. That is the direction that we're going in that instance, which means that there is going to be a left deviation on the axis of the heart's electrical activity. Now, let's say that we have negative in lead 1, now we're going down, but then we have positive in AVF, like so. We're going to go to our steering wheel, and we're going to drive. We start at normal. We're driving the electrical activity to the right. It's backwards because it looks like I'm going left, but we're turning this to the right side. So yeah, electrical activity is going to the right axis. Now if we're both down, we're just opposite of normal. We are extreme right. We're going so right that we're going backwards. So hopefully that makes sense. Might take a couple of watches or watch another video, might explain it clearer. This table is how to determine QRS axis using leads 1 and leads AVF. Everything that I just did. If a ventricle is enlarged, it contributes more electrical energy, right? So if the ventricle is bigger, that's where the heart's at. That means that there is more conductive cells, more electricity, more electrical activity that's going to show there. So you'd have a larger QRS in that instance. Resulting in the electrical vector points of the direction of hypertrophy. So one, the QRS is going to be bigger, but also it's going to be pulling more electrical activity. So that's what's causing that steering from moving from normal to whatever direction. Oh, I just ate, sorry. If an area of the ventricle is infarcted, if it's dead tissue, it has no electrical energy and the vector will point away from it. Identify the conduction system disturbances, so bundle branch blocks. A QRS complex with a bizarre appearance and duration of longer than 0.12, let's see if I can put that down. I haven't watched enough videos yet to see what the highest quality is. A QRS complex with a bizarre appearance and a duration longer than 0.12 seconds signifies some abnormality in the conduction system, right? Nice and tight, 0.11, that's our QRS. Our QRS should be not too skinny, but definitely not wide. Whenever it's too wide, that means there's abnormalities. A type of intraventricular, intra meaning in the ventricles, intraventricular conduction defect involving impaired induction from the bundle of His to one or more of the bundle branches. So right and left bundle branch blocks are the most common findings on the 12-lead EKGs. Right bundle branch blocks, RBBB, right bundle branch blocks. Terminal R and wave in lead V1. Terminal R wave in lead V1. So we're going to look at V1 and we're going to look at the R wave. Typically, the QRS complex appears as an RSR complex, R prime wave. Terminal S waves are also seen on leads 1, AVL, and V6. Terminal S waves, QRS, S waves also seen in leads 1, ABL, and V6. So 1 is horizontal, AVF, that's not AVF. ABL is left ABL, and V6 is all the way mid-axillary down here. I already know I'm going to struggle with this portion. That's why I'm doing this. In this figure, 12-lead electrocardiogram showing bundle branch blocks. What was bundle branch block? I'm pretty sure it was V2. Yeah, so I'm looking at V2. It looks like something funky's happening right here. You got a cluster of whatever this is. Well, you also got it at ABF and V3. Okay, so what did it say was happening if we have right bundle branch block? Right bundle branch block, terminal R wave in lead V1. Well, we were looking at V2. So this is V1. Okay, so electrical activity is shooting up, it looks like, but this is going down. Terminal S wave. QRS, terminal S wave. Don't know. Right bundle branch block, left bundle branch block aberration. Describe the shape of the QRS complex apparently in the conducted beats. Okay, so left bundle branch block, terminal S wave in V1, QRS, V1. All right, well there's a lot going on here. So we know there's more electrical activity happening in V2, V1, and V3. Where are those leads at? You got V1, V3, V4, V3, V2, V1, so this whole upper area of the heart, it looks like dead tissue, honestly, if that's the case, or it's just being pulled away in the opposite direction, which should be these, but it's not pulling. I always struggle with the 12 leads. Maybe this will say what's happening. Vesicular blocks. So also known as hemiblocks occur when the anterior and posterior fascicles become diseased or ischemic, or they cannot conduct electrical impulses. Vesicular blocks. Anterior vesicular block. So it's on the front, it's anterior block, RS complexes in lead 2, 3, ABF, and QR complexes in leads 1 and VL. So there's a lot going on. You really have to be on top of it for these. All right, lead 2, lead 3. So where's lead 2? Lead 2 is, that's V2. Lead 2 is up here, which means lead 3 is down in ABF. ABF is straight down. So it's going to be inferior. Anterior vesicular blocks it's going to be something happening towards the bottom of the heart. Posterior fascicular is going to be same, 2 and 3. It's still at the lower end, AVF, and instead of QR, RS complexes in lead 1. I need pictures of this. Bifascicular blocks is a combination of 2 or more blocked fascicles or other conduction pathways. So a combination vary and produce different effects in different patients. Right bundle branch blocks and anterior hemiblock. Right bundle branch block and hemiblock. Anterior hemiblock and posterior hemiblock, left bundle branch. Trifascicular block is when all 3 components are blocked or impaired, with one component still occasionally providing AV conduction. Concordant precordial pattern, when the QRS complexes in the precordial leads, that's your V1 through 6, are all in the same direction. Okay, so that's easy. That's, if you're looking for a heart attack, you're looking for myocardial infarction, and all of them are showing it. There's, what did it say? They're all in the same direction. You know that you have pericarditis. Yeah, pericarditis, inflammation of the heart tissue, pericardium of the heart. Has several possible explanations, including improper lead placement. So it could be that, it could be user error. Lead placement, anterior wall, myocardial infarction, or VTAC. Evaluate the chamber size for abnormality or hypertrophy. So right atrial abnormality was formerly called right atrial enlargement or right atrial hypertrophy. So right atrium will dilate if returning venous pressure is elevated or pulmonary pressures are high. So pulmonary artery going to the lung, if that's high, then the right atrium will dilate. And also the right side of the heart is where everything's coming back, returning, venous pressure is elevated, then it's going to dilate, it's going to be bigger because there's more pressure on it. Often associated with chronic pulmonary disorders. Characterized by a P wave with an amplitude of higher than 2.5 millimeters in lead 2 or higher than 1.5 millimeters in lead V1. So this, you just gotta go over all these. There's a list, a long list of rules that come into play, trying to figure out what specifically is going on with the heart at this level. Because you got 2.5 millimeters in 1 out of 12 leads, but you got to know specifically which leads. So in this case, lead 2 and or higher than 1.5 millimeters in V1. So we're looking at lead 2 and we're looking at V1. And 2.5 millimeters higher than lead 2, 1.5 millimeters higher in V1. Somehow memorize that, and that's going to mean right atrial abnormality. So this figure shows a 12-lead electrocardiogram showing right atrial abnormality. What was it? 2.5 millimeters in V2. So that's dipping pretty low. And then lead 1, 1.5, higher than 1.5. So that's higher than 1.5. About. Kind of hard. It's kind of on the nose a little bit. With an amplitude higher than 2.5. Would it say lower? Because it's dipping. That's what I'm not sure about.